welcome to Mad Medicine with Miss P. Today we're going to recap on the antihypertensives and kind of move into narcotics, which are not remotely related, and this is why. So, with your antihypertensives, and something happened this week. I've been in pre-admission testing quite a bit, so the patients will tell me their list of medications, and then we go through all of the disease processes, which, again, I find very ironic that that's what I've always done. I've heard other nurses I work with ask for all of their disease process, like they'll ask them all the questions. Have you ever had any restless leg, multiple sclerosis, Parkinson's, Alzheimer's? They'll kind of go through the whole thing. But if they just got the med list first, and if they knew their meds, they would already know all of those other issues, right? So ironically, this new system that they fill out in the computer, which we're now filling out in the computer when they call us, if they didn't do it on their own, ironically, is the medications first, as it should be, at any rate. So they give me their list of medications, and I know I said this last couple videos. Sure enough, 40 of Lasix, 25 of Carvedilol twice a day, lisinopril, metoprolol, and then I say, do you have any CHF or kidney failure? Nope. Like you do. You do. You take 40 of Lasix. You do. And my favorite is this sweet little lady I talked to, 95-year-old lady whose daughter thought she was my only patient for the day, on the phone 28 minutes. Bless her. They're so sweet, but oh my gosh, I wanted to pound my head into the wall. And, she says no to all these disease processes, and I get this list of meds, and then she tells me that she takes 40 of Lasix, when she needs it, 3 times a week. I'm like, that's not really how Lasix works. That's like, taking birth control, when you need it, or an antibiotic a couple times a week. Like that's not really how that works. I mean, yeah, it will help the problem that day, but then the next day that problem is still there. The reason you're taking it, the damage that you have, that's still there too. God bless them. I can't. So, sure enough, I talked to this other man, and he takes, 40 of Lasix and Carvedilol and all this. So, and I say, chronic renal failure, stage 1 or 2. He's like, nope, no, doctor didn't say anything about that. So then I send for the information from his cardiologist, and yep, chronic kidney disease stage 3, as well as, CHF and coronary artery disease, because he's on isorsabide. But he's like, nope, I don't have any of that. You do, and those medications that you're taking, that's literally what they're for. That's the only thing they do. So it's ironic that even now I get to see that, and oh my gosh, I had to get 10 different cardiology information for patients this week. I've never had that many ever, so it's crazy. But the last couple weeks, I should say, because it's just a 3-day-a-week event for me. So yeah, very involved, and they can deny it all they want, and then I get the paperwork and it's in my hands and showing me exactly what's what. So it just is, my point is, it's consistently reiterated to me that what I'm saying is fact. You don't have to like it, you don't have to agree with it, you can, argue with it, but that is in fact what's happening. There's no way around it. That's a simple truth. So, and I bring up narcotics at the end of this hypertensive issues, because I know my students have had this issue plenty of times. They come to me and they say, my patient's blood pressure was really high, and I told the nurse, and she said, okay, well, she's in pain. I'm going to go give her Lortab soon. I'm like, that's again, that's not how that works. If you're treating uncontrolled hypertension with a narcotic, you're doing it wrong. That's not okay. In fact, like I said before, if this little girl's blood pressure coming out of general anesthesia is 98/54, and she tells me she's at a 10 because she just had a painful procedure, she just had a ear surgery, tympanomastoidectomy, she just had a gallbladder or breast implants, I'm going to give her fentanyl. I'm going to give her IV fentanyl. That's what she's going to get. And it doesn't matter what her blood pressure is. It matters that she's breathing and that she's awake and that she can talk to me. Then it matters. But letting someone writhe in pain because their blood pressure is low and not giving them a narcotic, that doesn't work. And it doesn't work the same way as trying to treat their uncontrolled hypertension with a narcotic. So read how narcotics work, whether it's hydrocodone, oxycodone, Dilaudid, hydromorphone, whatever medication you're giving, meperidine, they all work very similar in the sense that they kind of block the receptor sites from you feeling that pain. So it doesn't make the problem any better. It's not fixing anything at all. It's simply you stopping the reception of that pain, or you're not receiving that pain receptor. So it doesn't make it okay. I'm not saying that don't use them. Listen, I had surgery not too long ago. I was very happy to have my Dilaudid. It didn't do as much as I was hoping it would do, which is odd because if I smell the cap of an Arbor Mist bottle, I'm lit. But I'm not saying don't take them, and in certain situations you definitely need them. But if there's an ongoing chronic issue and you're just trying to cover it up with narcotics, it kind of, and I mean to your patients, not like you specifically, but it kind of reminds me of like, sort of thing is a lame analogy, but like if your husband's cheating on you and you wore like really dark glasses so you couldn't see the text messages from his girlfriend, or you couldn't see, lipstick on his collar or whatever it is. I'm like, that's not fixing the problem. And in turn, that problem may even get worse if you don't see it, recognize it, and treat the core symptom of whatever it is. The fact that you're married, to a giant jerk who's cheating on you. So whatever the issue is, covering it with a narcotic, probably not the best idea. In surgery, we have to. I mean, it's acute, but chronic and long-term issues, I hate to see that because you really want to get to the root of that issue, whatever it may be. And sometimes it's not fixable and you have to take narcotics, and that's fine. But just make sure that anytime you give a narcotic, your nursing considerations, and we didn't get into that with meds too much, and I try not to because I kind of feel like it's common sense. If you're going to give someone a narcotic, the first thing I tell all of my students is you're going to first check their respirations. You're going to check their level of consciousness. Ideally, make sure there's something, in their stomach before you give them an oral narcotic, IV not so involved. And then, of course, rate their pain. Assess their pain. When did it start? When did it stop? Makes it better? What makes it worse? Where is it? Location, point with one finger. Be specific, right? Not just like, oh, she's got a headache. Well, if there's a brain bleed and you're giving her a narcotic, you're not fixing the problem at all, right? If she says, I have a sudden onset of upper back pain and shortness of breath, and you give her a narcotic and she's got a friggin' PE, you're not helping things at all, right? So get a really good pain assessment. Then you're going to treat that same thing with all the medications, all the antihypertensives and the antiarrhythmics. Don't overthink it. It's real common sense. Before you give any antihypertensive medication, you're going to check their blood pressure. You're going to encourage them to dangle and not get up and out of bed without help. You're going to make sure that their route to the bathroom is clear if you have to get them up, fairly quickly without being able to dangle, or if they try to get up on their own, you don't want them tripping or falling over anything if they attempt to get up quickly, and sometimes they do, no matter how much you beg them to dangle, right? You're going to check their heart rate because, of course, that matters. Not necessarily that it's going to affect it, but it lets you know if they're going to compensate with each other. Can you give it knowing the heart rate may go up or down depending on what happens with this medication? Those are your common sense nursing considerations. Please don't write down all that other crap with your rare and unlikely and bizarre side effects. Those are all unlikely, especially these patients have been on these medications for years. It's unlikely in the sense that if they were going to have those issues, they would have had them already. And the side effects are not going to stop you from giving the medication. If they develop a cough with lisinopril, yeah, they may change that to something else. If they're, allergic to something, which means that medication turned them red, made them itch or swell, yes, you're going to give them something else. But for the most part, before putting all of these rare adverse reactions or side effects in there for your nursing considerations, you're not going to look for those things. It drives me insane when someone says like, and I know my students, you guys have heard me say this all the time, when, it says like, monitor for crackles before you give metoprolol. I don't even understand how those are related. Metoprolol can't cause crackles and it can't make crackles go away. So what they're saying is that if this patient is taking that medication, most likely they have congestive heart failure, chronic renal failure, and they're going to end up with a pleural effusion. So before you give those, look for CHF exacerbation and acute chronic kidney disease or acute kidney injury on chronic kidney disease. I guess that's what they're saying, because otherwise it doesn't make any sense. If you hear crackles, you're not going to say, wow, I hear crackles in bilateral lobes. I'm going to hold the med. I'm going to give the med. They're not related. It makes no sense whatsoever. So when you see a nursing consideration like that in the book, you have to understand the pathophysiology of the disease process, what they think this patient may have of why they're on it, and then what the medication is going to do. It's certainly not going to stop either one of those. It's not going to stop crackles. It's not going to make it go away. Or like monitor for pedal edema. Okay, so if they're edematous, are you not going to give them their metoprolol? If they're edematous, are you going to hold their carvedilol? That's not a thing. I may check their heart rate, and most of your beta blockers say hold for a heart rate less than 60. which means 59, they're already bradycardic. So right. So there's already an issue going on there, unless they're a runner. And sometimes metoprolol says hold for heart rate less than 50 because it's not going to significantly drop it. We talked about how these medications work. They stop things from getting worse. It's a beta adrenergic blocking agent. It stops things from getting worse. It's not going to make them better. So I know I didn't touch on the nursing considerations, and we can go back to them if anybody, wants them, or you've got questions or anything like that, message me and I'll do it. But for the most part, those are the common sense things. You're going to check their heart rate, you're going to check their blood pressure, and recognize what these medications are going to do. And which means you have to understand atherosclerosis, systolic hypertension, aortic insufficiency, and all those things to really understand how and where these medications work. But as far as the narcotics, that to me is the biggest issue. I know people think that it directly affects blood pressure. It doesn't. Like people out there that are dying of fentanyl poisoning or overdosing on narcotics, it's not that their blood pressure dropped so low they stopped perfusing, they dropped dead. They stopped breathing, which in turn made everything else stop, and that's how they died. So you have to understand that if the patient is non-responsive, or their breathing is really shallow, or their respirations are below 10 or 9, no, I'm not going to give a narcotic. But if their blood pressure is 90/40, and that's normal for them because they're a tiny little thing, or they're a runner, or there's not much to them, I'm not going to hold their narcotics if they tell me they're in pain, especially if there's a legitimate reason for them to be in pain. And there's a bunch of different little questions and issues we can put in there. But for the most part, recognize that narcotics don't treat hypertension. And for you nurses out there that are doing that are saying like, oh, well, you're probably in pain, so I'll give you your narcotic and that will help your blood pressure. You are part of the problem. They have uncontrolled hypertension. If pain automatically caused, I just said this, if pain automatically caused this wild, uncontrolled hypertensive state, then every woman in delivery would go into a hypertensive crisis, and every POW or every soldier hurt in war would just go into a hypertensive crisis and have a brain bleed or stroke out or what. Those things aren't. That's not how that works. That is not how that works. You have got to understand that narcotics are for pain, and yes, they would affect your central nervous system, but that doesn't necessarily mean they're going to affect your cardiovascular system. No one has said like, oh, quick, she's an SVT, get some Percocet. That's not how that works. Oh, he's in a hypertensive crisis. Hurry with the IV Dilaudid. That's not what we give them. We give them vasodilators in a hypertensive crisis. An SVT, we're going to give antidysrhythmics, or they may get adenosine or shocked or whatever we need to do depending on what that exact rhythm is. Narcotics are not for hypertension. Please stop doing that. And if you haven't figured that out, that a lot of people that take narcotics regularly still have uncontrolled hypertension, right, because they have other issues going on. They have a constriction issue. It's not just about pain. Yes, your blood pressure will go up when you're anxious, nervous, worried, upset, scared, or in pain, sure. But not 210/106. That's uncontrolled hypertension. Just accept it. And that was the big issue with narcotics. Otherwise, you're gonna give them out. I mean, you're gonna pass them out like candy. We always have. We always will. People have uncontrolled and chronic pain. Generally, the biggest issue is inflammation, but people don't want to fix that. And I really like when they come into the emergency room and you have a very seasoned anesthesiologist or ER doctor, and they're like, "Oh, you're in chronic pain. Okay, well, we'll give you some Stadol." Or there's another one that escapes me right now that was always a favorite because oh God, it starts with an N. Oh, it's on the tip of my tongue. They're agonist antagonists. So you get the pain relief, but you don't get the high. So you'll find that those frequent flyers in the emergency room, I'm not assuming they all are. There are some drug seekers out there from time to time, and they tend to want to tell you that they're allergic to those agonist antagonists because they want the high from their Dilaudid or their morphine or whatever they're coming in and asking for. So, what are you going to do? Okay, so that's about it. I don't want to bring you down with all my pet peeves, although there are plenty. Well, we'll just do this one, and then I might end them with fabulous things that patients tell me. I will say this. If I have to get in the left lane to pass you, and then once I'm in the left lane, we're side by side, and you speed up, I think I should be able to just ram you right off the road. I feel like I should just be able to just drive my car into yours and just knock you off onto the road. Now, I haven't done that, and I probably won't because I don't want to ruin my car. It was my mother's car, and it's 22 years old, and I don't think it can take the hit. But if I speed up to go around you, Don't speed up to the speed that you should have been going in the first place as I try to get around you. What is wrong with you? Courtesy. Just takes a little courtesy. All right, as always, face your fears, forget your failures, follow your faith, hugs and kisses, 15 seconds. Well, 15 seconds away from 15 minutes. One of these days, this is going to work. I could have been right at that 15-minute mark. You piece of crap! Just, what am I doing wrong?